Well, I hope we've sparked your imagination with the notion that you can get innovators creating products and services, learning the hard lessons of 12 years, layering that on top of new installations and bringing that rich experience to the patient and doctor experience. So I'm going to start with two questions and we'll open it up for Q&A to the group. The Mission Act is extraordinarily important. And you know, I mean, so people are mobile. They're going to be seen in multiple locations, sometimes in person, sometimes telemedicine. They're going to be seen on Cerner and Epic and Athena and eClinicalWorks and Meditech and God only knows what else, because there's a very long tail of different electronic health records in this country. So let me open up the group and say, you know, think about your roles and your companies if the notion is creating a good VA experience. You know, how does working in the context of multiple EHRs with multiple patient identifiers and a lot of the kinds of interfacing complexity you guys have all described, how's that going to work?
Well, we do it today already, in that we sit at the top, you know, like a Travelocity, across multiple different providers. I think the key is, again, being able to map semantically across different EMR providers and what they mean, bring that into a single inventory and be able to sort and filter through it. The powerful part that we learned early on, and I think will bode well here for the VA as well, is that there are ways of nudging referrals around a network. And so our application looks exactly like Kayak. There's a nav bar where instead of saying, you know, take off after 9:30, you say 5 miles from my home, and instead of bringing back airplanes, we bring back physicians. It turns out the order in which you bring the physicians back on the screen matters a great deal, because like with everything in commerce, 66% of people pick the first person on the list after finding a female who speaks Spanish. And so we work explicitly for health systems, and Oliver and I talk about this a lot. You have to pick a stakeholder in healthcare. You either serve the consumer first and foremost, the insurance company first and foremost, or the health system first and foremost. So we serve our health system. And so we actually have explicit conversations with them around, how do you want to order the doctors on the screen? Do you want to put the new doctors who are 30% booked first and make sure they get filled up until they're a certain part, you know, and you can put them through the rotation? Do you want to put your employed physicians before your affiliates? And so I think this will be part of the conversation here around the governance, is how do you want to bring back at the term level different providers? And maybe when we have some organizations already, most of them, you know, want to reduce leakage and coordinate care within a defined network, but some of them recognize we just can't serve that service line in a profitable way. So we're actually going to selectively leak those terms to a different health system. And I can imagine it would be something similar here, where we actually want, by condition or by service line, to say, hey, we want to keep it within these networks, or begin to actually incorporate other networks in and allow that patient then to sort of, you're never limiting the patient. They can always go to page 17 and find a provider, but you can influence how they think about care with how you rank them.
Great. I think we'll go down the line.
Okay.
And you can pass if you want. That's okay, too.
No, I think from kind of our perspective, what we're seeing right now, again, things are already happening that way, in that, you know, we're in about 30 different health systems, hospitals, and because we have sort of this cluster in Boston, almost every single hospital in Boston and some in Massachusetts are on our system, we can actually see when a patient moves from institution to institution, which is really neat, because then we have another deeper layer of insight. But the more important thing is, because we're learning about individual patient at that level, about how they prefer to be communicated with, how they prefer to receive instructions, etc., we can actually apply that knowledge even when the patient moves to another institution. Now, I say that because the VA has a huge advantage over everybody else already, in that, in theory, should all be connected already. So when a patient does move from VA, it's not, I know, but in theory, we're going to get there. But as the patient moves from, you know, VA hospital to VA hospital, or even potentially seek care outside, the idea is to follow them and you know, have a really engagement profile of them and be able to have that continuity and experience. So that's how I would say.
Great.
Yeah, so I would echo, I think, what the two previous folks said. Integrating across EMRs is tough. We have a very large data acquisition team that just specializes in just that. That's all they do is working to establish integrations. One thing that I will say, and I think we're in a unique perspective as Change Healthcare, is that we're the technology operator of the Commonwealth Network. And so we have access to a lot of great data within that, being able to move across settings of care and then leverage that data to drive experiences. And so that's something that we're definitely exploring on my team, the digital experience team, is how we can take that Commonwealth data and then use that to drive connected care across settings of care.
Yeah, I think that's a great question. I think here's so we also do this already across hundreds of different scheduling systems. For the patient, it's completely indistinguishable which scheduling system any given provider is under, because they really don't care about this. As Kayak told you, these are Airbus and these are Boeing airplanes. Like, for the most part, you're indifferent to that, except for the grounded ones. What we do and what our belief is that, yes, you can, on the provider's website, you can tailor your experience to what, the institution wants. But on the internet, the other website is only one click away. And if you don't serve up the best option to the patient, that patient will do that one click and they will go where they find the experience that they really want. And so what we do, instead of trying to constrain what a patient can choose from, we're working with our clients to tell them, hey, these are the factors that we have seen are really important for a patient when they choose. And so you might want to think about how your service is actually delivered when you're open, where you are opening new clinics. Like, where is the supply and demand mismatch? We know where patients are looking in a community and where there are no providers. And you should try to meet the patients where they want you to be, instead of trying to force them into the offering that you happen to have. And obviously this doesn't happen overnight, but it's at least good to have a roadmap for this journey. And that's sort of the value that we can deliver to our provider partners.
Well, great. Well, thanks. So my last question is going to be an edgy one, right? Because even though these are the greatest innovators that I know, there is always innovation to be done. So I mentioned my 81-year-old mother. Now, what did I do for her last month? Well, I happened to be in Los Angeles. She refuses to move to Massachusetts. Too cold, too hot, just won't do it. And I put a Nest thermostat on her air conditioning and her heater. I put cameras on the outside of her home. I put certain light switches and plugs and Wi-Fi connected. I put Chromecast devices on her media, and I gave her a home hub. Now, she doesn't have any idea what the brands are or the services behind this or subscription fees or the plumbing or the APIs. She just walks up to her home hub and says, turn on the lights, make me comfortable, play some music, all this sort of thing, right? That is her interaction. She doesn't use a keyboard or an iPad or an app or anything like that. And let me just sort of illustrate this. So, okay, Google, what is the temperature of the sanctuary main house? And so currently it's 68 degrees. So here, let's make it 69 degrees. So I've just raised the temperature of my mom's home, right? I'll put it back down. And when thinking about what you guys know, will the industry be able to offer to all the veterans? Okay, Siri, Alexa, Google, whatever. I need an appointment because I have X sign or symptom. Are we going to get to that level of ease of use for our customers?
It's on the cusp. So we have partnerships with IBM and soon to be another one, where we're powering a chat technology. And the chat is pretty sophisticated. It can understand, hey, I'm on the phone booking for my daughter. So it understands, hey, the person on the phone is not the patient, and so it's a pediatric case. And we're powering, when they start saying symptoms and all the rest of it, they're powering other parts of it. But that is coming. I think with everything, and just to return back to some of the stuff you were saying earlier on, I don't think a technology is going to fit everything. So the edge cases, you are going to have to get on the phone with someone. And I think what we're already designing for are experiences, and we powered it at Piedmont actually with these loyal, where it starts with chat, and then at some point it says, you know what, we need to get you on the phone with a real person. And I don't think that's actually a failure, John. If you can still unload 15,000 appointments a month digitally, that's 15,000 calls that are not going in. Now you actually have space to bring those to bear. And again, I just think it's another example of how all of us actually, Oliver and I work together at many clients, we all are going to work together to actually accommodate different parts of the workflow.
Any other comments on that?
Yeah, it's coming. I think there are at least 3 other companies, and John, I think you know them too, working on exactly that. And the way I sort of think about it, if you can dream it and you've got an opportunity to make a difference and build a company, I think there are going to be people trying it. So it's sort of like self-driving cars, we know that's coming, and voice-activated healthcare, that's coming too.
Yeah, I do that too, where sometimes when I'm traveling, I scare my wife by turning on and off the lights, just so she knows that I'm out there.
That's called gaslighting.
Yeah, I want to be different, but I'm going to agree with the other 2 folks. Yeah, it's coming. I mean, so the challenge, or the lack of the challenge, is actually on the Amazon side, right? If you want to integrate with an Alexa, if you want to integrate with Google, the APIs, the SDKs, they're there, right? The documentation is there. It's not hard. The challenge is integrating the healthcare data into that piece and getting the data from the scheduling systems in a way that Amazon, Google, Siri can be able to read those. We've done that. We've piloted a payments application via Alexa, so you can query your statements, query your balances with your provider. So yeah, it's a matter of time to be able to bring it to scheduling. But I think the question is, rather than when, it's just, how is that going to happen? Is this something that we can have? I'd be able to query only one provider by adding an app to my Alexa, or could I query all providers through a ZocDoc type service? And I would hope it's more so the latter, but in my view, we're probably marching closer to the former.
All right, let me be the contrarian here. I don't think this is going to happen. And the reason why I don't think it's going to happen is because it's a terrible experience. Imagine booking flights over Alexa, and Alexa reading you out that schedule when which plane takes off, and that is insane. And we should take advantage of the fact that our visual system can process this kind of data much faster than our auditory system that's all sequential, which doesn't mean that Alexa and other technologies don't play a major role in healthcare. And in fact, I think one of the key bits is that, to your container analogy, the openness to these other modalities is key, and being a good ecosystem player is key. And so, ZocDoc is always opening itself up to new care modalities that have nothing to do with seeing a patient in office, right? You might want to see someone through telemedicine. Now, I'll tell you this. We have 6 million patients a month, but I can count the ones that type in telemedicine to begin with on my extremities. But that doesn't mean that when you actually educate them in the moment that they're looking for a traditional type of care, that, hey, telemedicine is available, that you cannot get quite significant adoption of that, right? And so there are other things, asynchronous care, instant prescription, things like that need to all be filtered in. And the learning agenda for us all should be, when is the right time to offer this, right? Like, for what kind of chief complaints, and how do you inform the patient sufficiently so that they actually feel they can make a non-conventional decision? Because that is the fear factor of, like, I don't know if this is really going to help me, so I might rather go with what I've always done before. This is our job. I think ZocDoc has a particular role to play just because of our scale and because we can reverse engineer the thinking and help shape the thinking in a completely disproportionate manner. But that is what we all need to figure out, and a system like the VA is, I think, really well positioned to be on the forefront of learning it. Be looking forward to that exchange.
So to summarize what they've just said is that the technology that you can imagine is technology that's likely going to happen. It may not be tomorrow, it may be a year to 2, but you also be careful of the use case. So we've built a dozen active Alexa scripts, and the kinds of use cases we've done are, when should I take my medicine next? right, actually works really well because it's not a visual thing or complex or that sort of thing. Or when is my next appointment? Or can you remind me of my care plan?
25% of the calls coming to our call center clients are to cancel an appointment. That's it. And a human being has to pick up the phone and do that. So I agree. It may not be everything all at once, but there are going to be bits we can bite off that are going to be relatively easy to solve.
Right, and so you could imagine that one of the modules, one of the containers that is offered over time for those patients who want it, offers some kind of Siri, Alexa, or Google Home kind of functionality for some aspects of the workflow. But we'll all be very careful. And it won't be technology for technology's sake just because it's cool. It's because it's meeting a customer need. Well, we have about 10 minutes left before lunch, and so let's open it up to questions from the group. I know you're getting hypoglycemic, and we're not going to be between you and lunch.
So, Mike Davies, VA. So, fascinating discussion. Thank you so much for all of that. One question I have is about the fragmentation of the record. As a provider, I can see all of the great ways to access a schedule. Have your telemedicine visit with somebody in the, I don't know, the Middle East tonight because it's day for them or something. And then how do you connect back, the bits of the record so that you have a complete, comprehensive view of what you've done, going forward when it could be life or death, in terms of what's next?
Well, I'll give you guys a stab at it, and then I'll answer. Go ahead.
All right, now that I know that the correct answer is coming later, I'll be very short. I think the agency is ultimately with the patient. So ZocDoc has the largest personal health record in the country, meaning patient-maintained health record, and that can be sent to any one provider that they go to. So this is, I think, one step in this direction. The other bit is obviously as you design choice architecture for the patient, you should be thinking about how do I make sure that there is continuity of care. So what we find is that 80% of our patients end up going back to the same primary care provider, and the 20% that don't, they gave them less than 3 stars to begin with. So there was probably not a good chemistry between the patient and the provider to begin with. And so there is obviously something where you never want to put constraints on the patient and on what they do, but you can give them the infrastructure to manage this and to understand. Even just remembering what the doctor's name was that I went to last time is quite a feat for some of them, and you can have all of this in one place irrespective of what system they were on. So whether you went and saw someone for a flu shot. And that is... yeah.
I think the question is what information do you need at the time to schedule versus what do you need to actually care for the patient? So we don't tap into the EMR today. We use basically the keyword drives. So we ask people what it is that they need, and that begins to drive the clinical triaging of it. And then we're often taking in either through our system, if we've had a longitudinal record, or we're typing into Salesforce or Microsoft Dynamics, and the preference is there for a female who speaks Spanish, their primary private provider, those kind of things as well. We do think, and I think this is maybe where you're going a little bit, to maybe bend the travel analogy a little bit, how do we think about first-class seats versus coach? And I don't mean that in a socioeconomic perspective. I mean in terms of an urgency perspective, right? Airlines have gotten very, very good at holding first-class seats until the very end, realizing they're not going to sell it and they'll upgrade you from coach, right? How do we think about that as well in terms of, hey, I've got 2 people calling in with chest pain. One's an 18-year-old kid who started lifting weights. He's got a little chest pain. The other was a diabetic who was in last week for a stent. I need to get her in right before the 18-year-old. So we're beginning to think about that. And I don't think it'll be tapping comprehensively into the EMR, but there may be things you look for. If it's chest pain, you might say, I need to know 3 things. Is it a diabetic? Is it a this? Is it a that? Okay, that's going to bump it up from an urgency perspective. We're not doing it today, but we're beginning to think about those kind of things.
I'll just take one stab at it. So I think it's the billion-dollar question, right? About how do you be able to present the information in such a way that the clinician, the provider, I don't know if clinician is a dirty word today, but so that they're able to use it in a meaningful way. And in our experience working with ACOs, for example, trying to be able to take data from one EMR, they get 40% of the record, and then data from another EMR is 60% of the record, and then match those together is an incredibly difficult problem to solve. And I don't think that anyone has solved it well. I mean, we think that we've solved it pretty good, but it's not a 100% solution. So it's identity matching, it's deduplication, and it's data aggregation. And those are issues that we wrestle with every day, but make it tremendously complicated.
So, okay, I think it would be useful for the report if we have a little sidebar on Commonwealth and care equality, because these are two infrastructures, two organizations that will help answer your question. So our friends at Epic, I think there's a couple of Epic folks in the room, care equality turns out to be a data governance framework and standards implementation guide producer that ensures that rules of the road are followed by all who want to consume data that is fractured in the U.S. healthcare system. And we've all looked to them to write these DIRSAs, these data use agreements and that sort of thing. And they did a great job on data governance and standards. But sometimes you actually need a little infrastructure, and such is that infrastructure that's hosted by Change called Commonwealth, that is a master patient index and record locator service for the country. So if Graham, let's say he trips and falls outside on Fifth Avenue, how do we know where his records are to be found? Well, you could either query in real time 500,000 ambulatory care sites or 5,000 hospitals. That would not be scalable. Or you could say, okay, Spencer, can you tell us anyone who's ever been registered by the name of Graham Gardner who has this age or these other characteristics? And admittedly, because we don't have a national healthcare identifier or a nationwide patient matching strategy, it's not going to be perfect. It's going to be pretty good, though. You'll actually see that he has a record at Beth Israel Deaconess Medical Center, and if you've signed the DIRSA with Care Equality, you can go and query that and get the data and put into a standard form, and we use some of the standards that I started with to do that. So what you're hoping, because Cerner and Epic actually play very well together across Care Equality and Commonwealth, as do all the pretty much other mainstream vendors these days, it's not that distant in the future that you're going to get to Graham's point. It may not be everything, but it's going to be the key elements that you need to ensure that that service for that person is arranged in a timely manner.
For me, it's actually much easier because as a good cardiologist, I haven't seen a doctor in 25 years, so there just aren't.
Perfect. Well, we have time for one final question.
Mine's real quick. I'll just say, at VA, we very much think and are moving towards inpatient care as option B. So what I would like to see for us is to be able to have the offering not just for a patient appointment slot, because a lot of times patients in our system, it's difficult for them to travel. So if we're driving by symptoms and we're saying that you have a rash, you can use this app, and we can leverage the specialty providers across our entire enterprise to say, we have dermatologists, but they're kind of sparsely populated. They tend to be coastal, but let's use their schedules and plug them up for asynchronous care. And that I think is something that we really need to uniquely leverage and do more of.
Yeah, so we're actually going live with American Well in a couple of weeks down in a hospital in Florida, and I think you're exactly right. And one of the benefits we see in having this big vocabulary is you can basically pick out what 7% of those terms are ideally suited for telemedicine, and you can actually begin to route runny nose or rhinitis or rashes and begin to offer up, do you want a telemedicine visit? Do you want to see a physician in 2 weeks? Do you want to see a nurse practitioner in 2 days? And begin to kind of expose different inventory based on what it is that they're looking for. But we do see telemedicine as a huge part of the future, particularly for the VA, I think.
And this notion of matching supply and demand with telemedicine solutions is very powerful. I do 900 telemedicine consults personally each year because I am the nation's expert in poisonous mushrooms and plants, and there is no other emergency physician, board-certified expert who's malpractice insured to do that. So every poison control center in the United States uses me in a telemedicine telecare consultation. And so it's exactly as you say. It's right question routed to the right person with the right supply and demand match is clearly where we want to go. Well, great. Well, thanks so much. We are at time, and I look forward to seeing you guys this afternoon.